Welcome everyone to today's webinar, The Great Migration, Shifting High Acuity Spine and Orthopedic Procedures to the ASC. On behalf of Becker's and surgery partners, thank you for joining us today. I'm Ayla Ellison, and I'll be your moderator for today's discussion. Before we meet today's speakers, I'm going to go over a few agenda items and some quick housekeeping details. We will begin today's session with an around the horn panel discussion, and we'll have time at the end of the hour for an audience question and answer session. You can submit any questions you have throughout the program by typing them into the Q&A box you see on your screen. Today's session is being recorded and will be available after the event. You can use the same link you used to log into today's program to access the recording. There are a few different engagement tools you can utilize during today's event. Additional resources are available for download in the resources widget on the left-hand side of your screen. There is also a brief survey on the right-hand side of your screen, and we thank you in advance for your feedback. Finally, if at any time you don't see the slides moving or have trouble with the audio, try refreshing your browser. You can also submit any technical questions into the Q&A box. We are here to help. Now, I'd like to welcome our esteemed panel. We are thrilled to be joined by Dr. Kenneth Nuoso at Neo Spine and Microsurgical Spine Center, Dr. David Shaw at Valley Bone and Joint Clinic and North Dakota Surgery Center, Trent Webb, who's the Senior Vice President at Surgery Partners, Central Region, and Nicola Moreland, Clinical Nurse Specialist, Outpatient Total Joints and Advanced Surgery Center. Thank you all for joining us today. Now let's dive into the discussion. So my first question today is for Dr. Nuoso. Spine surgeries have evolved over the past several years, but it isn't widely understood what's considered high acuity and what's lower acuity to be routinely done in the ASC. Can you speak to the different case types and what you are currently doing in the ASC?
Sure. First of all, thanks for having me. First of all, that's a question with multiple different parts. And first of all, I want to dive into sort of the evolution, of these surgeries into the ASC. And it's primarily driven by the market pressures to, enhance the value of care that we provide to the patients. And for me, I try to simplify things. What is value? Value, providing an enhanced value is sort of providing better outcomes for a lower cost. So the ambulatory surgery center plays a natural role, especially in the cost component. However, the question, now becomes, all right, from the standpoint of surgeries that are done in the hospital, what can we control to allow these cases to be done in an outpatient setting? So for example, if the reason why a patient is in the hospital and would require sort of overnight stay is due to pain, then the question is, okay, what can we do pre-op, intra-op, and post-op to mitigate that pain to allow the patient have a good outcome, even though the patient is discharged on the same day? So from the standpoint of value, I think that we can provide a significantly improved value in the ASC setting. The idea of high acuity and low acuity, that's actually, the lines between high acuity and low acuity has been blurred by, market players with competing interests. However, there's many studies that actually indicate what cases can be done in the ambulatory surgery setting versus not. From the standpoint of the different cases I do in the ambulatory surgery setting, I'm able to do most of my cases in the ASC, decompressions, fusions of the neck and the low spine and the lumbar spine. There are cases that should not be performed in the ASC, and mostly these are cases where patients are critically ill and where patients are consuming a significant amount of opiates, in cases that may take a longer period of time. So those are the cases that I'm currently doing in the ASC.
Thank you so much, Dr. Nuoso, for walking us through that, what you're seeing, what you're doing in the ASC. Our next question today is for Dr. Shaw. And the question is, what are technological advancements, surgical techniques, or pain management protocols that have enabled you to perform high acuity procedures in the outpatient setting more efficiently?
Yeah, again, I'd like to thank you for having me. There has been quite a bit that's changed over time. If you look at surgical techniques, the way I'm speaking mainly of total hips and total knees and partial knees, but the actual surgical techniques for myself have really not changed over the last 20 years. I still do a lateral approach to the hip. I've not changed my approaches. Same with the arthrotomies for knees. So the actual surgical technique has not changed. It's just everything around it has. I've changed some things in regards to I do press fit total knees without cement. That simplifies things. I've gone with and without the tourniquet. But surgical technique hasn't changed a whole lot. I think the biggest thing that's changed in my practice really is the protocols and the pain management. Having a set schedule and a set system to give patients the medications before surgery, during surgery, and after surgery. Before surgery, I have a protocol where they get all their preoperative medications, their pre-surgical medications, and that's fairly standard based on the patient. We do adductor canal blocks, and I think adding the pre-op pain regimen as well as adductor canals, that's really allowed us to change from a hospital setting to an outpatient setting. Intraoperatively, I also use Exparel, and I found that has worked well. That's also going to control their pain, afterwards. Post-op, we do the same thing. All the patients are on a set protocol with the medications. We have a schedule. We actually have a flow sheet. So when that patient leaves the hospital or leaves the surgery center, they have all their medications. It's all been reviewed through the nurses, and they've actually had a set protocol to take their pain medications. And so I think by being able to randomize it and control it in a very set situation, we've been able to really manage and control the pain. So for me, I think the anesthesia, the pre and post-op pain medications, the multimodal pain management protocols have really helped. I think the other real big thing that probably plays just as important part is really education. Is all my patients before their surgery, they see my physician assistant who I work with. They spend about a half hour going through everything in regards to surgery, their medications, what to expect, and that they're also seen 3 or 4 days after surgery. So there's a fairly tight control in regards to them flowing in from the first time I see them, their pre-op discussions with my physician assistant, as well as afterwards. So it's very closely monitored, but we've been able to make things reproducible. And I think the other thing is really it's been an all buy-in. I mean, our pre-op nurses, our post-op nurses, and really our anesthesia. Once everyone as a team, kind of sees that vision that it can be done, it really makes a big difference. And I think that's been the biggest thing that's allowed us to be successful, is really the education, the pain management. The other thing I did is when I started transferring patients, higher acuity cases such as total knees, total hips, and partials, I started out with partial knees. I was already doing about 100 partial knees a year. I started doing those at our surgery center. Once I became comfortable with that, I switched over to adding total knees about a year later, and I did the partials and total knees for a year, and then a year later I added total hips. So it wasn't all at once. It was a very gradual transition, but it really made things very smooth and reproducible.
Thank you so much, Dr. Shaw, for sharing your insights there. And we're going to go ahead and move on to our next question today, which is for you, Trent. And the question is, what are some of the key market trends that you attribute to the rise in high acuity procedures in the ASC?
Thank you, Ayla. Good afternoon, everyone. Thank you, Dr. Shaw and Dr. Noeso, for kicking off the conversation. You hit on a lot of salient points that I may reiterate a little bit in this response, but I think it would not come as a surprise to anyone who's turned on the TV in the last 18 months that there's a severe compression on inpatient resources. So the escalation in the migration of cases has only accelerated since the start of the pandemic. But even before that, we were starting to see a number of high acuity cases like total joints and certain spine procedures move out of the inpatient-only environment. I think largely that's due to 3 buckets. You have your patients, you have your physicians, and you have your payers that are all have active components for driving that. So from the patient standpoint, Dr. Shaw touched on this, but from an education and understanding that a patient is going to have a great outcome, a safe procedure at a lower cost is something that we've worked hard as an industry to help educate the patients. Also from just a personalized level of care and more concierge type approach to our patients, it keeps them satisfied, happy, and having an overall great experience. From the physician standpoint, I think history shows us that physicians are the driver of change and of the change to move these cases from an inpatient to an outpatient environment. It certainly helps a physician to have the technological and clinical improvements regarding better anesthesia blocks, better access to certain specialized equipment at a surgery center. Also helps the physician's convenience. Being able to schedule a full day with their full scope of cases at a surgery center certainly aligns those overall incentives. And then from the payer standpoint, there's constant pressure that we see in the market to find a lower cost alternative for certain procedures that's in a safe and effective way. You see that with the rise of value-based arrangements. You see from the CMS removing certain procedures from the inpatient-only list over time, as well as just the overall pressure to move to a lower cost environment.
Thank you so much, Trent, for providing that more broad overview of some of the key market trends that are contributing to what we're seeing and what the doctors spoke about at their ASCs. Our next question here is for Nicola, and we just want to know, in your opinion, what are the clinical best practices imperative to a successful spine or outpatient orthopedic program like Total Joints?
Well, I appreciate the opportunity to speak today. I think I'm in agreement, of course, with my prior presenters. We're all of the same thought process there. But in the broad sense, I think on the clinical portion, working as a nurse navigator who sort of is backup and able to tie this all together in the facilities that these outpatient procedures are now being performed, that there really has to be a very clear understanding right from the get-go that this is going to be an outpatient procedure, because historically, most of the population are understanding that these procedures are historically done in an inpatient setting, and will come across family members who say, you know, my great aunt went to hospital for 3 nights, how can you present this to me? So I think it's really important that from the get-go that all the stakeholders have a full understanding that this is outpatient procedure. These patients will be going home, and as Trent said, going home safely with great outcomes, which is so very important to the patients. So the stakeholders, as Trent says, you know, really our patients primary and foremost, our physicians, and of course our facilities that we're doing these procedures now in an outpatient setting. So patient selection really starts with the physicians in their office, their ability to recognize which patients are a good candidate for this outpatient setting. There are several parameters out there that would exclude a patient, whether it be a high BMI, history of any type of transplantation. So screening in that surgeon's office, and once that patient's passed over to their outpatient setting of choice for the patient, the inclusion has to be that the patient's screened initially over the phone to make sure that we're not catching any red flags that this patient really, you can discuss with the surgeon that this needs to be an inpatient setting. So you're looking at maybe testing an A1C or hemoglobin, making sure that if they need cardiology or pulmonology screening before scheduling, then we're not having the patient in the wrong channel. And then making sure that you're understanding the patient's nicotine history, their narcotic use. Are they naive? Have they had a long history of narcotic use? And as we discussed a little earlier, controlling pain has been pivotal in moving this to the outpatient setting, both whether it's spine or total knees, total joint replacement. And then just making sure that there's the parameters that are needed to be met by the patient are going to have a coach or somebody with them that are able to assist them at home, assist them with the understanding of what their role will be at home, For the physician, the nurse navigator who works in the surgery center is able to back that surgeon up to be able to review any pre-op evaluations that come in, able to do a joint replacement class with the coach, make sure the coach understands what their role is, and also to have a group within the outpatient setting that will assist the physician. The physicians are comfortable, that the staff in their OR and the nurse navigator understands the whole of outpatient setting and not new faces continuously. And of course, for the facility, as Trent said, it's got to be cost effective. We have to make sure that we've got implant pricing from a clinical point of view, that we actually do have block time. So the surgeons are really able to do multiple of these more intense surgeries to be able for it to be cost effective, making sure we've got surgical throughput on the whole perioperative continuum. And then again, finally, I guess, quality follow-up once a patient goes home.
Thank you so much for walking us through all those clinical best practices and sharing your experience. I want to turn the floor back over to Dr. Nuoso now for our next question. And just as a provider performing both inpatient and outpatient high acuity spine and orthopedics, what would you say were the initial contributing factors that helped you take the leap into the ambulatory setting? And then after that, I'd love to discuss what has remained a non-negotiable for you to perform these procedures in the ASC.
Sure. I would say, first and foremost and most importantly is having an adequate, support staff and having them bought into the vision. I would say that's the most important thing. And then beyond that, understanding the literature, behind what you can do safely in the ambulatory surgery setting versus not. And third, having enabling technologies and enabling techniques. For example, we've started doing endoscopic spine surgeries in our surgery center. And what's nice about these surgeries is instead of stripping the muscle tissue, you're going in between the muscle tissues, and you're able to perform an adequate decompression, of nerves with an incision that's less than 1 centimeter, right? So now you have a patient that's BMI of 45, which was previously contraindicated to do in the surgery center. And now with this enabling technology, you can do the surgery safely and effectively at a lower cost in the surgery center. We also have a robot that allows us to, precisely and accurately place pedicle screws in the surgery center. And this just sort of, enables us to perform these surgeries safer, more efficiently, and at a lower cost. So those are some of the factors that contributed to me transitioning some of my higher acuity cases into the ASC. And the follow-up question, what remains non-negotiable? I would say, the patient factors and patient education and setting expectations to the patients. There's some patients that come in and you tell them that they're a candidate and sometimes they don't get it. And sometimes they have catastrophized, they tend to catastrophize. These patients wouldn't be good candidates to undergo surgery in an outpatient setting. And there's some patients that are critically ill, patients with COPD, patients with metastatic, disease, patients that are malnourished. Even though it may seem that, you may be able to perform a 1-hour surgery safely in the surgery center, you just never know. So those are sort of the non-negotiables to me.
Thank you so much. And Dr. Shaw, we'd love to get your input on this question, or actually the original question and the follow-up as well. We'd love to hear your insights here too.
Sure. In regards to the initial contributing factors, I think for me, I was obviously, as we all were, we were all doing cases at a hospital, and for me, part of the push is really just the autonomy and decision making. When you go to conferences, you go to courses, you see things in the literature. I think part of it was the frustration of trying to do those things at a hospital in a big system where I'm not employed by the hospital, so obviously it was really hard to make change. And so there'd be literature things that would come out, and one is because couldn't really make change or have any impact on your care of your patient. It was really kind of out of your hands. So for me, that was kind of the initial factor. I had a lot of trepidation at first and anxiety, especially going from unis to totals. For me, a lot of it was hard I didn't quite know how to make that discussion to a patient and say, these are your options. And just like they stated before, most of these patients have had family members who, they had a total hip or total knee 10 years ago and they stayed in the hospital 5 days. And they looked at you like you were crazy. And I think the COVID actually really accelerated things. I started really kind of doing a lot more cases at our surgery center and making that push, both total knees and total hips, and COVID came. And I had already started doing total knees and total hips, but I all of a sudden started having many, many patients come to me and say, I don't want it at a hospital. I actually want it at your surgery center. So for me, it was kind of it was obviously a terrible situation, but patients didn't want to stay in the hospital. And so I actually have had to talk patients out, for patient safety and other reasons. I mean, I've had 80-year-old patients come in who live alone and say they want it done as an outpatient. So the COVID is and I think the mindset that we can do it safely, I agree totally in regards to the literature. I think I was fortunate in regards to when I made the switch. There's a lot of literature out there looking at 30-day readmission rates, surgery centers versus hospitals, complications, other things. And really, it showed that we can do all of these high acuity cases safely and reproducibly at a surgery center. And for me, I think once one had the backing of the literature that it could be done safely. Two is it gave me the autonomy and I could control, and I think I provide better care and I think I have better outcomes. And that's kind of snowballed to some degree, just because patients do, I'm in a smaller town of 50,000 people and patients tell other people. And so I think it's really been a bonus in regards to, there's been a lot of momentum that's been created just on itself. In regards to, I agree what was stated previously. My non-negotiable is really, patient safety. The parameters and protocols have changed over time in regards to what we think we can safely do at surgery centers and even hard stops. But, a lot of it is just sitting down and talking to the patient. And oftentimes I will get, a gut feeling where on paper the patient's a perfect candidate. And after talking to him, you realize, for multiple reasons, it should be done as an inpatient. So it really comes up to patient selection, and I think that's important. Probably the only other modifier that would be, if I have bigger cases in regards to revisions with stems and augments and other things, just the cost of the implant really precludes you from doing it at a surgery center. So that's really probably the only other thing. But other than that, I think it really comes down to patient selection, patient safety.
Thank you so much, Dr. and Dr. Nuoso, for sharing your provider perspective there. And I want to turn the floor over to Trent now to hear about what are the key considerations to ensure good economics in launching an outpatient spine or orthopedic program.
Absolutely. I think for any enterprise, it is critical that you prioritize your deployment of capital, make sure that what you're moving forward with is the best use of your resources. So you need to develop a comprehensive picture of what the program looks like, from an intake flow of your total cases, your reimbursement, your cost, et cetera. So the specific questions I ask are, what the number of cases and the types of cases. And for those cases, do your payer contracts cover that? And if not, where are your gaps? That gives you a good sense of kind of where you're going to come in from a top line reimbursement standpoint. And then you obviously have to dig in, as was mentioned previously, around your supply and implant costs. Those can certainly make or break the program. And then also, one thing we haven't really touched on a lot is any physical plant improvements that are necessary. For example, adding in these two high acuity specialties, you certainly need significant size ORs to make sure you have enough room, and would your ORs accommodate that? Any investment in the robot or other technologies, again, are going to be key decision points on whether or not the program moves forward. And once you have that full understanding, that gives you a go, no-go feel, or do you want to phase the introduction of these higher acuity type programs? Dr. Shaw mentioned starting with uni knees and then progressing to total knees. Dr. Nuoso, similarly, moving to higher acuity spine cases over the course certainly gives you that flexibility, lowers the learning curve, and gets a full buy-in from the staff, and overall makes the economic sense for the program to proceed or not.
Thank you so much, Trent. And our next question that we're going to move on to today is for Nicola. And outside of the initial patient selection criteria, what additional assessments can a physician and or clinical personnel like a total joint navigator do to ensure a patient is a good candidate for outpatient surgery?
I do believe that Dave was, Dr. Shaw, was absolutely on the money where he addressed, you can see a patient in your office, think it's a good candidate. The same on the nursing side when the nurse navigator sets up a total joint class with the patient and the coach that's going to be with that patient, who also receives the education before surgery, comes on the day of surgery to help the patient go home, and then is at home with the patient for a designated period of time. The nurse navigator is really able to lay eyes on the patient. We're looking for anything that would be contrary to patient safety for them having that particular type of surgery in an outpatient setting. So actually physically laying eyes on the patient themselves, so looking at teeth, looking for signs of infection, swollen ankles, looking for anything that perhaps even the primary care has not picked up on or the patient is not aware of if they haven't been for the preoperative history and physical at that point or had that H&P done by the nurse practitioner in the office. So that nurse navigator can actually lay eyes on the patient. That nurse navigator is like a second line of defense to be able to talk to the coach and the patient to find out what kind of occupational therapy home situation that these patients are going home to. We've already discussed medications and the importance of pain medications following surgery and the addition of any type of regional block that's routinely being done for these cases in the outpatient world. So we're sending patients home with blocks, with narcotics that can be taken at home. So the nurse navigator really needs to be able to look at the respiratory side, doing some kind of screening for sleep apnea, whether it be stop bang or any other healthcare assessment for respiratory to make sure these patients are safely going home with additional narcotics that wouldn't add to any pre-existing respiratory problems. Physical therapy is either done by the nurses at the facility or outside physical therapy providers, depending on the surgeon's preference. But again, at that joint class, the nurse navigator is going to be able to see how that patient is able to mobilize, talk to them about stairs, how are they going to get in and out of the car, how they're going to manage at home once they are having their initial recovery prior to seeing that surgeon on the first post-operative visit. So I think PT and OT is a big portion of this, along with anything sort of clinical system-wise. So then that nurse navigator is going to be able to report back to the surgeon at that initial joint class. We're going to be able to know if the coach is bought in. I think that's very important, both for the patient and the coach. So that gives the patient and the surgeon some sense of security that this patient is going to have a second set of eyes, be able to have those safe outcomes that we absolutely require for any outpatient total case like this at this level. So it's really, additionally from doing that joint class prior to surgery, also being able to review any preoperative testing that comes in and report that back to the surgeon, this continuous communication, so we're not letting anything slip through the cracks, and on day of surgery, you've got a patient that's well prepared.
Thank you, Nicola, for walking us through that and sharing your experience and insights. I want to ask one more question of Dr. Nuoso. and that is, following patient selection, are there any payer or patient-driven factors that have influenced your decision to perform these cases at an ASC?
Sure. Obviously, we have to remain financially, viable. So, being able to be reimbursed for the work that we do is important. And I think there's been a rapid transition, specifically with CMS allowing for sort of reimbursement for cases that were previously inpatient-only cases. And obviously the managed care payers have followed suit. So I would say the rapid removal of inpatient-only spine surgeries has been a major factor to me doing more cases in the ASC. But then on the flip side, like Dr. Shaw mentioned earlier, there are sometimes more complex, higher acuity cases that I would be interested in doing. However, it becomes harder to justify this financially given the very high cost of doing this surgery. So oftentimes I'll just take these cases to the hospital. From the standpoint of patient-driven factors, I would say, time and time and again, and this is getting borne out in the literature, and I'm seeing it firsthand with my patients, that the satisfaction rate is much higher when you do these surgeries in the sort of outpatient surgical center and when they go home the same day. And however, on the flip side of this, like Dr. Shaw mentioned, it's absolutely invaluable to make sure that these surgeries are being done safely. So patient safety is extremely important.
And Dr. Shaw, is there anything you would like to add onto the question about the payer or patient-driven factors that are influencing your decisions?
No, I agree with Dr. Nuoso totally. I agree with, I'm currently not dealing or working with bundles. We don't have any contracts with, any large companies or other places, and that may play a role down the road. I look at implant costs. That's probably the only other payer factor. We have a very good payer mix, but there is different insurances where I don't quite understand, where I can't do it at a surgery center. I can do it at a hospital as an inpatient, keep them overnight, but they won't let us do it. So there is some factors, but it really doesn't, I think, affect my practice much. And I agree totally in regards to patient-driven factors. I think the other thing that's really interesting is, if you look at the whole experience, and the experience at a surgery center is completely different than, experience at an ASC. And I think that's a patient-driven factor where the demand comes in regards to, if I do a total hip at the hospital, they're getting physical therapy, they're getting occupational therapy, they're getting their basic met panel, their hemoglobin, they're getting all these things that really the literature shows that they don't necessarily need. If you look at, I love physical therapy, but if you look at physical therapy, occupational therapy, post-op labs, on most of these patients, the studies have actually borne out that they're really not cost effective. So the other thing I think that gets missed is we can do a procedure where the results likely are going to be better with a lower infection rate. The patient satisfaction is going to be higher. But the other thing is it's much cheaper for the whole healthcare system. And so, I think it's something that as a healthcare system, it has to really look at all these things that we're doing that's really not evidence-based, and we're doing them just because because everyone before us was doing them. And now I think the literature really is showing that there's a lot of things that are done and currently being done at the hospital that really aren't necessarily needed. And so I think that's why the experience is different. But I agree totally with Dr. Nuoso.
Thank you so much, Dr. Nuoso, Trent, and Nicola, for that terrific discussion. And we will now take some questions that have been submitted from the audience. And as a reminder, you can submit any questions in the Q&A box you see on your session console. So during the discussion today, we already had several questions come through, so we're going to go ahead and get started with those now. And the first question that came through for our panelists is, how do you feel the COVID-19 pandemic has or has not impacted the ASC industry?
I can start, and then feel free, any other panelists, to weigh in here. I think certainly at the beginning of the pandemic, for the lower acuity type cases, for sure, there was an immediate slowdown, or if not complete cessation of cases for a 4 to 6 to 8 week period, depending on where you were. But the higher acuity cases, that impacted a person's health and livelihood, were able to be continued to a certain extent. Once the COVID numbers decreased and elective surgeries began ramping back up, we did see the additional migration in certain markets of cases that we may not have seen previously, just because the fear out there of being in a hospital from a number of patients, maybe don't contract COVID while in the hospital, certainly drove them to ask more questions than they did previously. So we were able to see a pickup of interest, certainly, in patients having their procedures done outpatient versus being done traditionally in the hospital.
Thank you, Trent. And
I would concur with that we did have that slowdown when we had a spike of COVID initially in the area of America that I was in. But once that was lifted, we saw those cases come straight back to us. And during joint classes, the nurse navigators do report that patients are very attuned to hospitals or where the COVID cases are. They don't want to be in a hospital. And so perhaps turning more and more to the outpatient setting for that extra level of safety of not getting infected.
Thank you so much, Nicola, and thank you, Trent, as well. We've had several more questions come through, so we're just going to keep working through these. And the next question for each of our presenters today is, what ASA score would be your cutoff?
Yeah, I can start there. Typically it'll be, an ASA score 3 and above. We try to avoid doing those cases in the ambulatory surgery center. However, I try not to be, too dogmatic with what I would do in ASC or what I would not do in ASC. Like I discussed earlier, if you have a patient that comes in with a high ASA score and they have a disc herniation, and I can decompress the nerve with an endoscopic surgery, while the patient is under conscious sedation rather than general anesthesia, well, that's an ASA 3, possibly an ASA 4 case that I can do. So, from the standpoint of sort of criteria on paper, we try not to regularly do ASA 3 and above. However, every case is treated differently, and there are some ASA 4s that can be done in the surgery center. And I do kyphoplasties in the surgery center for ASA 4s all day.
Thank you, Dr. Shaw. And would Dr. Nuoso or any other of the presenters today like to add anything to that question or that response?
No, this is Dave Shaw. I would agree with that also. The other thing we do is anytime I have a case where I'm just not quite sure, the chart and everything is actually reviewed by anesthesia. I had a case that actually canceled today, and I saw the patient. I thought they probably would be a decent patient. I was kind of borderline. They were sent to our anesthesia team, who does an exceptional job of going through everything, and they just said, you know what, I think this patient would best be served having it done at the hospital. So I did it at the hospital this morning. So, I think having that checks and balances, and I also don't question. I mean, if the anesthesia says, they don't think it can be done safely, I mean, for me, that's a hard stop. So I think having a really good anesthesia team like we have really makes a world of difference.
Thank you, Dr. Shaw, and thank you, Dr. Nuoso. Nicola, I'll let you weigh in now, too.
I think the nurse navigator who is looking at these patients prior to surgery, like I said before, has been able to pick up on things that perhaps are not always caught in the doctor's office. Their time is minimal. Joint class can take between 45 minutes and an hour. And you also have the opportunity of involving anesthesia right then and there if you have some concerns. And as the physicians have said today, this is not a hard stop parameter. We prefer to do a safer outpatient. But the reality is that our population, the BMI is getting higher, patients are getting sicker, we're seeing more diabetics. And so while we can look at the patients, on paper they may look different. If you're doing joint clasp prior to the surgery, you're able to involve anesthesia. Anesthesia plays a very pivotal role in who they are able to safely perform surgery on and who are they not. Our surgeons are very respectful of anesthesia and their decision whether to proceed, or maybe this patient is generally a little sicker, but they feel like it's still a good fit for the surgery center and will therefore approve that particular case.
Thank you, Nicola. And the next question, I'll open up the floor for responses as well. The question is, what reimbursement challenges do you face from your ASC procedures? And if you could help provide some examples, that would be great. So once again, just what reimbursement challenges are faced by you from your ASC procedures? And I'll just open up the floor for whoever would like to chime in first on this one.
Again, I'll start. We certainly do face those. Every market is different. Every payer within those markets are different, have different policies around reimbursement. Education is critical here, to have those ongoing conversations with the payers to explain to them the cost of the procedure, so that they understand that by shifting it to the outpatient site of service, it is a lower cost environment, but we still need adequate reimbursement to be able to do those cases, because we have much thinner margins and we're able to accommodate those cases, but only if the margins support that. So from a reimbursement standpoint, it's a ongoing conversation with payers. Specific examples around that are negotiating implant costs for both total joints and for spine procedures. For your screws, your cages, your different knee and hip constructs with the various vendors, those can range broadly based on the vendor. And so certainly having those conversations with your partner surgeons, helping them understand that, not all implants are created with the same cost. It helps educate the overall partnership in the surgery center, as well as the payers, to what makes the most sense to utilize moving forward, and able to do those cases on a cost-conscious basis.
Thank you, Trent. And would anyone else like to add anything to that question as far as the discussion around reimbursement challenges? Okay. And we've had several more questions come through for the group today. So this next question is a little bit longer, so I'm going to read through it and then open the floor up for responses. So this person says, of course there are exceptions, but do you see a better recovery rate for like-type patients who have a service in the outpatient ASC setting versus as inpatients? And are there less infections? So I'll just open up the floor for that part of the question first, for whoever would like to chime in there.
Overall, I think, in regards to infections and complications, I personally, the infection rate, obviously already is very low. I do between 200 and 300 cases. So overall, we track our infections. I do think our infection rate my infection rate is a little bit lower at the surgery center, but I don't know if I have the numbers to really make that substantial in regards to the power. But I do think, I do think the patient satisfaction is definitely different. So every patient I see, when I see them post-op and they're done at our surgery center, I actually ask them, are they happy? Could I do anything different? And how is their experience? And I've had multiple patients where I've done their other knee or their other hip at a hospital, and they stayed at least one night, and I recently did their other. And I can think on one hand how many patients had any issues. So I think actually my patient satisfaction, I do think my outcomes are better in regards to the overall pain management. And I think it's because we're able to be consistent. I have the same staff, we have the same people. You know, like I said, the person who's actually seeing them for a half hour, 45 minutes, going through all their education and information is the same person who's seeing them 3 days after surgery. And it's the same person who's in the OR. And so I think there's a definite continuity of care that you don't get at the hospital, but I do think that comes over to both patient satisfaction. And, you know, I would think that my complication and my infection rate is lower, but again, I don't have the numbers to back that up.
All right, now I'll sort of corroborate everything that Dr. Shaw is saying. I mean, there are numbers to back up the fact that the infection rates are lower doing spine surgery in the surgery center versus in the hospital. And I think obviously this is confounded by the fact that, you know, you're doing more complex cases in the hospital versus a surgery center. But even when you control for those confounding factors, you find that the infection rates are lower. And I think it's primarily just due to a more controlled environment, you know, and a more sort of consistent and reproducible sort of sterilization process, and just an environment that you know, that doesn't consist of a lot of sick patients with multiple medical problems. From the standpoint of patient satisfaction and patient outcomes, you know, I would say in the surgery center, you know, they're superior compared to the hospital. Most of this is anecdotal, but you know, I feel that this is the case primarily due to the consistency and the reproducibility of how we do things in the surgery center. You know, we have protocols in place that are performed every single time we do these surgeries. You know, when patients are under anesthesia, they're not given a significant amount of opiates. It's the same anesthesiologist most of the time. And you know, all patients get steroids, they get anti-nausea. So when most patients wake up from anesthesia, most of them aren't nauseous. So I would say the consistency, the reproducibility makes the patient's outcome and satisfaction better in my perspective. And I would say that there's a significant amount of support in the spine literature at least. And we're talking about, you know, pooled data from multiple different studies that have shown that the infection rates are statistically significantly lower in the surgery center compared to the hospital.
And I would like to reiterate, when I was speaking, I was talking about my own, but I agree, and the orthopedic literature is the same, is that the patient satisfaction is higher, the infection rate is lower.
I would concur with all that's been said before. I think added to this mix, you have a patient that's coming for an outpatient surgery. Once they've got that full concept and understand, and they're given that most important education, they're able to take on board their own outcomes. So you end up essentially with a patient who has an understanding of what they're going to go through and go home. They also have an understanding that they have a direct influence on their outcomes. So you've got a patient who's going to get up and walk and move, not be in a hospital bed, not waiting for a nurse call bell, being able to assess what pain medications they need, if they need to take any kind of medication outside of their regional blocks. They're able to make those own decisions if they're well educated and they have that support of the coach. And we see that tie very much to patient satisfaction. So in the outpatient total joint world, which is what I am most familiar with, is we're seeing patients that are coming back for the a repeat knee, another side knee replacement, or the other side of the hip, and they're coming back to the outpatient world, or they've been in an inpatient facility and then luckily come over to the outpatient world and had a good experience. Gives them a lot of satisfaction that they've had some control over their own outcomes, and able to go home, able to demonstrate they're safely, can manage themselves and have less problems because they're walking, they're not having as many blood clots, they're not having as much, they're washing their own hands, they're not in contact with sick patients in hospital. And so I think all these factors together help to give you a patient that really has some more responsibility for their own outcomes. And therefore, we're seeing less infections and we're seeing higher patient satisfaction. It's a beautiful thing.
Thank you so much, Nicola, and to the other presenters today that shared your insights as well. we are going to continue to work through questions until the top of the hour. So please, if you have questions, continue to submit those. Our next question that came through is for Dr. Shaw. And this person said, I heard you say that the cost of the implant can preclude whether a procedure is in an ASC versus a hospital. So can you elaborate on that?
Yes. So at an ASC, my implants, total knee, total hips, as well as my partners, whether it's suture anchors, they are actually not covered by most insurances. And so the surgery center, really eats the cost of those implants. So any total hip, total knee, or partial knee I do, with very few exceptions. There is some insurance companies who will pay a portion, or there's one that will pay all. But most of the implant cost is actually not paid for by the insurance. So we actually eat that cost, and that's part of our overhead. And as Trent stated, that's why, we do have, smaller margins, obviously, because of that. And so that's where it is really important to meet with your vendors, to look at your implants that you use, and really, because you're paying for that out of your own pocket. And you're doing that to make it work, because honestly, if patients have better outcome, and if my day is greater, if I even the financial aspect aside, it makes my life better and my patients have better outcomes. But the cost of the implants does definitely play a role. And as a general rule, it is not covered by most insurers.
Thank you, Dr. Shaw. And the next question that came through, the person is just complimenting the presentation, just thanking you for the excellent information, but they also want to know if you can provide any insight regarding key considerations for a cardiovascular service line.
Yeah, I myself, for cardiovascular, I don't know.
I would have to say the same. I don't have any experience to date with implementing cardio program in, but I think we've discussed some of the similar tenets that would be required to implement a program around cardiology. But if we can get the contact info from the person posing the question, other resources when surgery partners can reach out and provide that information.
Great, thank you so much. And we'll make sure to follow up to get the information that person needs. The next question is, what % increase of procedures being done in the ASC do you think will be done over the next 5 years? So Trent, do you want to start with that question and then we can move on to our other presenters today?
I think from our perspective, we're largely dependent on CMS continuing to remove certain procedures from the inpatient-only list, and then other managed care providers will follow suit on a reimbursement standpoint. I think the goal would be to do as many of those procedures that are safe to be done in an outpatient environment. That's going to be relying on getting the appropriate training for the staff and the technology in place to do that. But from an accommodation standpoint, I know all of the facility administrators and staff I work with love a new challenge and really are excited about bringing on additional procedures to the surgery centers.
Agreed, and I'd like to sort of add that I foresee over 80%, possibly even 90% of spine surgeries being performed in the ambulatory surgery center. And I think the limiting factors would be sort of patients that are critically ill and surgeries that take a long time. And from the standpoint of what surgeries those are, I would say, in the spine world, those are deformity surgeries, where you're correcting a scoliosis curve. Those surgeries take on average 7 hours. So if you're operating on a patient for 7 hours, naturally the infection rate increases, blood loss increases in other, morbid conditions. But ultimately, beyond those cases, every other spine case, in my opinion, can be performed in an ambulatory surgery center, including sort of, anterior, sort of abdominal, retroperitoneal, fusion surgeries, where you're around the sort of great, blood vessels in entire country, so to speak, given that you have sort of blood bank capabilities in case things go downhill quickly.
In regards to orthopedics for total hips and total knees, the statistics that I have seen is that by the year 2030, 75% of all total knees and total hips will be done as an outpatient in the U.S.
Thank you so much for providing those predictions, and it'll be interesting to keep an eye on and see how this increases over the years to come. We have time for at least one more question and maybe a few, so we'll keep moving through these now. And the next question today is, does a single specialty or dual specialty ASC have greater benefits and results than a multi-specialty ASC in terms of driving higher acuity procedures to an ASC? Dr. Shaw, I can begin with you for that question, if that's okay.
Yeah, sure. I mean, our surgery center, we have, it's mainly orthopedics. We also have pain management, and we also have eye surgeon. And, I think it's still somewhat limited, your specialty. I mean, we all work along with each other very well. And Trent, I think, would probably have a better answer in regards to overview, but there is really no issues at all with us in regards to having multiple specialties in one center. I think it really comes down to room. If you have enough room, and we're also lucky we have absolutely incredible staff here, and they're able to handle, wear two hats. On Mondays, they can do 29 cataracts, and Tuesdays, they can do 4 joints. And so I think you can, and I think you can have multiple specialties working in one area. I think the whole key to it is having great, competent staff.
Right. And I'd agree. However, I think one thing to consider is between which specialties you're able to sort of obtain a superior amount of synergies. Based on what I've read so far, it appears that you are able to obtain pretty superior synergies when you have total joint replacements and spine surgery. However, when other subspecialties are operating in an ambulatory surgery center together, sometimes that can sort of impede the workflow and potentially cut into profit margins if the synergies are not there. And Trent, I'd like to get your thoughts on that as well.
Yeah, great points, Dr. Shaw, Dr. Nuoso, on both of those. I think it is critical, first and foremost, to have the staff in place that can handle whatever service lines that you do perform regularly at the surgery center. And that is where your competencies start. As far as layering additional specialties, we always like to look to see what's the most complementary, what makes the most sense to do with your existing technology and equipment in place. And what would be easy to supplement to add on additional service lines, like if we're talking musculoskeletal and you do orthopedics and you want to add spine, podiatry, pain management, it is much easier to move in that direction from just an overall staffing training standpoint and a service standpoint. But then, this is not to say you can't make a shift and bring in, another service line like ophthalmology or GI. But it comes back down to capacity constraints. And if your center is not large enough and you move to one of the more high volume type specialties like eyes or GI, then you have to be very cognizant of how that's going to impact the rest of your flow and the operations that are already taking place at the surgery center. So I think it makes sense certainly to start with complementary type specialties and then evaluate all the different considerations that are in place from there.
Yeah, I would weigh in that I do agree that you can put cohorts together. However, I think the day surgery setting has already demonstrated that the clinical staff can be very nimble. Alongside doing total joints, can also be doing some kind of orthopedics or pain podiatry that is similar, but able to do both at the same time, again, depending on how many operating rooms and what your surgical throughputs and how you build your block time to keep everybody moving through and not having, a step on the hose pipe, so to speak.
Thank you, Nicola. And one more question for Dr. Nuoso came through. And this person is just wanting to know, do you see interbody fusions ever moving primarily outpatient and fusions in general as well?
Yes. I am actually going through that transition currently. The transition of moving, lumbar fusions and interbody fusions into the ASC. I mean, cervical fusions, anterior cervical fusions have been performed in the ASC for years and years now. But currently, I am transitioning to doing interbody fusions through the lateral approach and through the posterior approach in the ASC, and that's being sort of enabled by sort of enabling technologies like utilizing the robot. I'll do a lateral interbody fusion and place the pedicle screws while the patient's in the lateral position, which sort of cuts down significantly on the surgical time and mitigates the issues that come with the workflow of flipping a patient from their side to prone. So, I think we're there now. And if it were up to me, if the patient was not critically ill, I would do all my 1-level, 2-level interbody lumbar fusions in the surgery center.
Thank you, Dr. Nwosu. And we have time for one quick question before we close things out today. And the last question we have is, what is the role of 23-hour stay capabilities in the growing spine and joint programs in ASCs? And I'll just open up the floor for responses to that one.
Well, right now I can just say that, we have a 23-hour capability for patients to stay. Knock on wood, I've been doing this for close to 3 years. We have not had anyone stay overnight. Our state has just passed legislation that now we can actually have a 48-hour stay, in the state of North Dakota. But, I go into it as I really do not plan on having anyone stay. But that may change down the road once we bring, if we do bring more high acuity cases over time. But I've not actually had to use a 23-hour stay. I know a lot of places initially were looking at, they were using hotel rooms and other places, but we actually just went straight to outpatients. And I think that where the big reason we were able to was really the education component and expectations.
And I'll precisely agree with Dr. Shaw on that.
Yeah, only to reiterate further here, both of Dr. Nwosu and Dr. Shaw's surgery centers have 23-hour stay capability. It is utilized if and when necessary, but the approach has always been we're outpatient surgery center, and that's where the bulk of our cases are oriented. And so we make sure that the patients understand that coming in.
Totally agree.
Thank you all so much. And that is all the time that we have for today, but I want to thank our wonderful panelists for their time and sharing their expertise with us. I'd also like to thank our sponsor for this webinar, Surgery Partners. And to learn more about the company, partnership opportunities, and their footprint in same-day surgical facilities, please visit surgerypartners.com. And as a reminder, take a moment to fill out the event survey. Thank you very much.
Thank you.
Thank you.
Thank you.